approaching 400, and the numbers are increasing. Thank you for joining us from wherever you are, from the counties, the facilities, from our partners. You're most welcome. My name is Dr. Janet Karemi, working with the Ministry of Health in the division of RAMCA, where I head the reproductive and maternal health section. It is a pleasure to be here with you this evening. As a ministry, as we continue scaling up the use of the Labor Care Guide, we are very encouraged by the strong and consistent participation we've seen from all of you. This is now the third webinar in the series, and the numbers are still high, showing the interest that is out there. Thank you again for joining. In the first webinar, we focused on majorly sensitization, introducing the Labor Care Guide and the key shifts from the pantograph that we've traditionally used. In the last webinar, which was the second one, we looked at how to actually fill in the documents and how to fill in each section, both for the mother and for the baby. We had practical sessions, very good discussions, and a number of questions, some of which we addressed that time, and others we shall continue to address even today. In this third session, we shift to the real work on the ground, the implementation at county and facility level. We focus on moving from the knowledge to actual implementation. We want to hear directly from those who have started using the Labor Care Guide, what implementation looked like, what had to change for them to use the Labor Care Guide, how did one trained provider support the others to build confidence to use the Labor Care Guide, and what challenges came up along the way, and how did they overcome these challenges. So today we'll have the real practical experiences from Vihiga County, Homabay, Nairobi County, and Kenyatta National Hospital. We are prioritizing this Labor Care Guide because it's not just a form, it is a form of quality control. It supports better decision-making, including aspects of respectful maternity care, and ultimately ultimately promotes better outcomes for mothers and newborns. So I encourage all of you to actively engage, listen closely, and reflect on how these lessons can be applied in your own county or in your own facility. It is now my pleasure to hand over to our moderator, Dr. George Gwako, who is a consultant obstetrician gynecologist and senior lecturer at the University of Nairobi, and a true champion in the adoption and use of the Labor Care Guide. He has really walked us through step by step in this journey. Dr. Gwako, over to you.
Thank you, Dr. Janet, for the introductions. And good evening, everybody, and welcome to tonight's webinar. I think the topic has already been introduced. So my role is actually very simple. What we're going to do is that as a follow-up to the last webinar, we'll have a short quiz. Then for those who might have missed the last webinar, we'll have a recap of what we covered. We'll also look at a few commonly asked questions about the Labor Care Guide. We've been receiving questions. We received questions during the last webinar, so we'll try to answer a few. Then I'll bring on board the facilitators for tonight's webinar. At the end of the webinar, again, we'll have a short quiz, so please don't log out. We'll want to hear from you how the webinar went and what else you might need in form of subsequent webinars. So to start us off, I want to invite Dr. Charles to take us through the Mentimeter questions.
Hello, thanks, Dr. Gwako. It's a few questions just to check the understanding of the Labor Care Guide. It will take a very short time, at most one minute or half a minute per question. So we can, Nelson, kindly project them. Yeah, thank you. You can put in the chat if you're able to see the questions.
Just to the participants who have joined us, kindly take a look at your screen. There should be a live quiz that is being shown on your screens. Kindly attempt the questions, and then this will help inform our panelists on your understanding of the Labor Care Guide. Thank you.
I'll quickly run through as you're doing so that so the first question is on the labor care guide. When should it be started? It's a multiple choice question, just pick the right one. Where should the labor care guide be used? That's the second question. The third one is, which of the following parameters are used to assess labor progress? We have fetal heart rate and cervical dilatations, uterine contraction, cervical dilatation and fetal descent, urine protein, acetone, fetal heart rate and cervical dilatation and fetal descent. The fourth question is on which of the following statements about reference thresholds for the different assessment parameters on the labor care guide is false. So the labor care guide has alerts and references. So which one among the four listed is false? The fifth question is on which of the following statements about active phase of the first stage of labor is false. Then we come to the sixth question. When the fetal heart rate lowers below baseline after the peak of a contraction, this is what? What do we call that? Number 7, when assessing the fetal heart head, you feel that one skull bone is overlapping another. But when you gently push the overlapped bone, it goes back easily. This is called, what degree of molding is that? Number 8, which of the following statements about duration of different phases and stages of labor is false? We have 4 choices there. Number 9, which of the following statements about medication is false? And then the last one is which of number 10, which of the following postures the woman may adopt in labor should be discouraged? Which posture should we discourage? The labor care guide is about choice and also about respect for the mom who is delivering. And also about enabling to deliver on the position of their choice. So which one is discouraged? Number 11 is this statement true or false? When an alert value is noted, you should take the action required and inform the woman and her family. Her consent is not required because she may not understand the medical situation and options for care. Is that true or false? How should you assess the fetal heart rate? That's the last question. So about 600 attendees, going to 700. I hope we've been able to, as you join, sorry, noted. So once you are done with the questions, kindly submit them. Philip, we can see the results, and then
To our participants who might be having challenges with seeing the poll, kindly just take a look at your screen. There should be some 3 dots with more. Kindly click there and see whether the polls are appearing there if it's not directly appearing on your screens, so that you can attempt the short quiz. Thank you.
so how many have finished? Maybe once you finish, you can indicate that you are finished so that we can. Yeah, thank you. Just one person. Yes. Let us all indicate once we finish so that we can move to the next. Thank you.
Thank you. Thank you, Charles and Nelson, for taking us through the Mentimeter and the questions of understanding how much we know about the labor care guide. Guys, this was not an exam, but just to guide the presenters on the areas that they need to emphasize on. So in 2018, the World Health Organization introduced a guideline on intrapartum care for a positive for a positive labor experience. Now, this guideline had 56 recommendations. There were some old recommendations that were done away with, and there were 26 new recommendations. So when you look at those recommendations, most of them will not be accommodated in the partograph as we knew it at that point in time. So the WHO then introduced the new generation partograph, which is called the Labor Care Guide. It was actually introduced in the year 2020, but you know what happened in 2020? We had the COVID pandemic. So this was put to the parking lot. But over time, the world again is moving now to implement the Labor Care Guide, including the Ministry of Health in Kenya. In the last, I think 3 weeks ago, we had the first webinar on the Labor Care Guide, as Doc had already mentioned, where we looked at the structure of the Labor Care Guide, why it was introduced, how different is it from the partograph as we knew it. And then we looked at the specific sections of the Labor Care Guide, how each section is filled. Now, out of that, we've still received quite a number of questions about the Labor Care Guide. And tonight, we'll answer some of those questions. One of the questions we were asked is whether the Labor Care Guide is implementable in Kenya as it is. So the answer is actually yes. And a few counties and a few hospitals have already implemented the Labor Care Guide, starting with our national hospital, Kenyatta National Hospital, Vihiga County, Homabay County, and also Nairobi County. So for tonight, We will listen from the horse's mouth from those facilities and counties that have implemented the labor care guide, so that for those who still wondering whether it's implementable, so that we can learn on how we can implement it in our counties and in our hospitals. Before I invite the speakers for tonight, allow me for 5 minutes to take you through some of the frequently asked questions on the labor care guide. So the common questions we get asked is, what is this labor care guide? So this is a tool that was developed by the World Health Organization, as I said, in 2018, rolled out in 2020, that to support evidence-based, respectful, and individualized care during labor. Mark the words evidence-based, respectful, and individualized care during labor. Another common question you get asked is, why was the labor care guide developed? And as I said, there is that guideline that was issued by the WHO in 2018 that had some new proposals that could not be implementable using the old pantograph. We will share this document from WHO in 2018 in the chat box as the webinar goes on. So what are the main components of the labor care guide? So the labor care guide has 7 sections, pretty much similar to the old pantograph. So it has a section on admission details, supportive care, baby care, woman care, labor progress, medication, shared decision making. I've added another component, the alert column. So the ones that are in bold are new. They were not in the pantograph as we knew it, but we covered these things in details in the last webinar. The recording is available. It might be shared with you. So then that begs the question, so what are the main differences between the labor care guide and the pantograph? There are quite a number. So for number 1, there are those 3 sections that I've talked about that were introduced. But some of the other differences that you'll notice is in the definition of active phase of labor. It's at 5 centimeters. Initially, we're starting at 4 centimeters. Evidence shows that the rule that we were taught in college, that a pregnant lady in labor should dilate at cervical dilatation, at a rate of 1 centimeter per hour, is not true. It's actually so fast for some women, and that rate does not predict an adverse or a good outcome. So that has been thrown away. The other difference you'll notice is that it supports a 12-hour fast stage if all the parameters are okay. Remember, initially, if a lady is in labor for X amount of time, even if the fetal heart rate is okay, everything is okay, the patient will be taken to theater for an emergency CS. So yes, you can monitor your pregnant lady in labor for more than 12 hours, but on condition that all the parameters are normal. Number 3, it introduces second stage monitoring for 3 hours. This was not in the pantograph. It now includes respectful maternity care, including pain management, having a companion during labor, ambulation, and allowing women to take food during labor. It introduces shared decision making. Anytime you make observations, you have to discuss with the lady and have a shared decision on her management. It introduces alerts. So for example, if you pick a heart rate of less than 110, what does that mean? What do you do? If you pick a heart rate of more than 160, if somebody came at 5 centimeters cervical dilatation and has not delivered in 10 hours, what are you supposed to do? So in short, it emphasizes communication between healthcare workers and our women, emphasizes on dignity, companionship, pain management, mobility, and hydration during labor. Another question we get asked is who, where, and on whom should the labor care guide be used? So this can be used by all healthcare professionals taking care of pregnant women in labor, in all levels of health facilities, and in all pregnant women, regardless of their risk status. Which begs again the question, can it be used in high-risk women, for example, women with preeclampsia, gestational diabetes, or diabetes in pregnancy? The answer is yes. But of course, for the high-risk women, then you'll need the support of the other tools that you normally use to manage them. Can it be used for twin gestation? Yes, it can, but then you use, if it's a twin or triplets, you use you use 3 of them. If it's twin gestation, you use 2 of them. Lastly, how frequently should the labor care guide be updated during labor? Does it replace clinical judgment? The simple answer is that the frequency of monitoring has not changed. So those parameters that you monitor half hourly, we still have to be monitored half hourly. Those that you monitor 4 hourly have to be monitored 4 hourly. Do I need any training before using the labor care guide? Yes, you need some training. And that is one of the reasons why we are doing these webinars. And the Ministry of Health counties and the partners are rolling out the training for all healthcare workers. The ministry will also answer this question. So, ladies and gentlemen, to answer the questions on implementation, whether it's implementable or not, the challenges, lessons learned, in Kenya, we have 4 eminent presenters this evening. Without using any particular order, our presenters, number 1 is Dr. Philomena Owende, who is a senior consultant obstetrician gynecologist and head of department, Kenyatta National Hospital. She's a leading expert in emergency obstetric care, complex maternal cases, minimal invasive gynecological surgery. She provides national leadership in clinical governance, specialist training at the University of Nairobi, and quality improvement in maternal and newborn health. Our second presenter, not in any particular order, is Lorena Akinyi Manguro. Lorena is a nurse midwife at Homabay County Teaching and Referral Hospital. She's a trainer of trainees or trainers in labor care guide and actively supports the adoption of evidence-based practices in labor and delivery. Very passionate about improving respectful maternity care and enhancing clinical client experience alongside clinical outcomes. Next, we have Robina Anene, who is a reproductive health coordinator at Nairobi City County. She's a nurse midwife and a health systems specialist, and who leads Nairobi County in efforts to improve maternal health, family planning, and adolescent health services. She's also engaged in a number of research activities, innovation, and including work on AI-enabled intrapartum monitoring. Lastly, but not least, Veronica Msiega is a Senior Assistant Director, Nursing and Midwifery Services at Vihiga County, has over 20 years experience in reproductive health implementation, mentorship, and capacity building. She's a national trainer in maternal and newborn health, including EMOC, MPDSR, and quality improvement initiative. So a very, very loaded panel. So I want to invite our first presenter tonight, Veronica Msinga from Vihiga County, to share the experiences from Vihiga. Welcome, Veronica.
So good evening, everyone. My name is Veronica Musiega. I come from Vihiga County, and I'm going to present on my experience on use of the labor care guide implementation in Vihiga County. I'm waiting for the screen. Okay, so Vihiga County, basically it's not a very big county. We have only 5 sub-counties. There's a 6th one that is will soon be developed. So we have a population of about 612,000, and the sub-counties are 5. We have a total women of reproductive age are at approximately 153,000, and we expect to deliver about 27,000 women in Vihiga County. Just a correction, it is not 42, but at around 27,000 per year for Vihiga County. So the sub-counties that are missing, yes, just as you could see on the map. So the experiences for Vihiga County when it comes to implementation on the labor care guide. So first of all, we are actually implementing in 33 facilities. So we have at facility level, we are engaged in training. So we first had the first mentor training at in our main county referral hospital, where we trained this county mentors and the sub-county mentors. That was around just about 10 of them. So we had the team from MCGL who supported us in one-on-one mentorship using the labor care guide. So we had the actual labor care guide and also the guide that would help us on how to actually fill them. So we also had the pencils and rubbers that were to guide us, the red pens, and we were taken through the labor care guide. So it was a session one-on-one. So we were taken through each component of the labor care guide, or starting from the initial, the mother's parameters at the top, the demographic data, then the supportive care. So it was slow as one could be able to feel, and the trainers were actually checking as we were feeling them, and they were observing on what we are doing and checking on how we are feeling and being able to correct. Using the pencils, we could rub where we are not doing well. Then that was again followed by supervision on how we are going to implement it in the main county referral hospital, so that they could see whether what we were taught during the sitting on one-on-one is being implemented correctly in our main county referral hospital. So again, now the 10 trainers we started rolling out in the 3 facilities from the orientation we had. So the 3 main delivering facilities were identified in the various sub-counties, and at least 2 mentors were rolled out to each facility so that they would support one another. And we also had the support of the MCGL team that came down to actually see how we are doing the implementation in the 3 facilities that we were able to roll down that particular time. So when we rolled down, after we had again to come and have a sitting with the mentors, the 10 mentors, and we identified the gaps that were at the facilities, and we were able to tackle them accordingly. So now after the 10 mentors, when we are doing the facility mentorship in the 3 facilities, we again were able to identify the mentors who are doing well in the facility-based mentorship, so that we also recruited them in the pool of mentors, so that at the end of the session, we had a pool of 20 mentors who are now going to support us roll down to the other facilities. So now we have a total of 20 mentors and who are TOTs in labor care guide, and they are continuously supporting the mentorship on labor care guide as we continue rolling out. So currently we were at 3 facilities, we moved to 9 with the 20 mentors, and then we are now at 33 facilities. And we are having public facilities here, and we also have our private facilities that are also high volume that our mentors have rolled down to. They are also implementing the LCG. So the total people that have been mentored on LCG in Vihiga County that are working in maternity and labor ward are actually around 124, but we hope to scale up to more providers, because we are having around 40 facilities that are able to conduct deliveries, and we hope to roll down to the other remaining facilities so that we are able to have all our mothers being monitored by the labor care guide. So we also do monthly audits so that, remember, we are doing, the mentorship is done slowly because we have identified peer practice coordinators at facility level. So those that we mentored, we may not get everyone at facility level. So when we identify somebody who is doing a very good, who is good at mentoring, we identify them, and those the people that are not on duty at the time of mentorship, they will continue mentoring them slowly. That is a low dose, high frequency. So that in case somebody is on night duty and we identify that they are not filling in the parameters as expected, then the peer practice mentor is able to, or coordinator is able to sit with the person for a few minutes and be able to identify why the gap is there and why they are not filling the various parameters of the LCG as they are required. So we do the audits again on monthly basis, the low volume facilities, but for our high volume facilities that we started with, the main county referral hospital and the sub-county referral hospitals, we audit the labor care guides every other 2 weekly, so that when we identify the gaps, then we give them a score, and then we again revisit where the gaps are, and we are able to come up with a work plan on how well we can improve on the gaps that are being identified on the ground. So as you can see the picture, that is now our pool of mentors now going through the labor care guide as guided by our lead mentors that actually helped us when we first introduced the LCG in Vihiga County. So now on service organization, we actually saying that we conduct mentorship in the county on continuous basis. And as I had told you earlier, we actually have the peer coordinators at the peer practice coordinators at facility level who continuously help us in improving the skills of our providers so that they are able to ensure that the labor care guide is correctly filled. Then we also have at sub-county level, the sub-county level and county level providers who will again do the audits, and during the audits, they will identify where the gaps are, and many times we have realized that the areas where we have gaps are like when being able to identify the position, the fetal positions, like the position of the occiput, is it anterior or posterior or transverse? That is an area we identify. We have identified that our providers have a gap in, so we have to keep reminding them using our mannequin models on how to actually identify the fetal head positions and being able to identify where the occiput is, because that we realize that the transverse position and also the posterior position are the alerts on our labor care guide. But as much as they are the alerts, we always encourage that you will continue monitoring labor. So if the posterior position will persist, then that is when you will actually need to take an action. Then the other areas that we realize during mentorship that normally is a gap is being able to monitor the contractions accurately. You realize that the contractions the provider must remain at the mother's bedside for like 10 minutes so that she's able to ascertain how many contractions the client is getting within the 10 minutes and what is the frequency of the contraction. That is a problem that some of our midwives are having, so that you will realize that they will not, many of them will not even detect when the actual documentation of the contractions. So we have to sit with them and even do it practically on the mother so that they are actually giving us a correct chart of the contractions. Then again, there is another area that we identify normally there is a gap. Yes, we also identify that during the assessments, some of them will circle the alerts, like the posterior position, they will, occipital posterior position, they will suckle, it is an alert. When the mother does not have a companion, it is an alert. When the mother is in a supine position, it is an alert. But when it comes to the actions down here, you realize some of them are not even putting the correct action in place, or maybe calling a relative from home to come and support with the companionship, or even ensuring the mother becomes mobile. So we have to keep reminding them of the gaps and the actions that are needed to be done when there is an alert, so that they are actually acting promptly, and we are not continuously recording that there is no companion, no, all through the labor process. Or maybe the patient is not mobile all through the labor process. So they need to take an action on the same. Then the other area is on fetal decelerations. So our midwives again had an issue on being able to identify the fetal decelerations. You realize that when taking the fetal heart, we must take the fetal heart of this mother if without the contraction, and also during the contraction, so that after the contraction, we are able to detect the late decelerations, which is an alert for this particular process. So rarely, sometimes we will not find that we have had an issue, but there is no charting on the labor care guide that we have had the late decelerations. So that is an area again we have continuously to go around our providers and being able to teach them on how to accurately take the fetal heart for 1 minute, be without the contraction and with the contraction, so that they are able to identify the late decelerations, because you realize the early decelerations is not normally an alert. So they should clearly identify which is the late deceleration that needs an action on the fetal heart rate. So that is some of the gaps we identify during the mentorship, but we have continuously gone down with them, and we have continuously guided our service providers on the ground and our peer practice coordinators on the ground. Again, we continue sharpening them so that they can continue following our providers and until we are able to achieve very good charting on the LCG. So what I can say is that in Vihiga, we have, I told you we are doing the audits, and wherever we identify the gaps, we are still being supported the MCGL. So we have to keep going continuously on monthly basis and identify the files that our providers are using, because we already have our LCGs on the file, in the files. So we have to keep identifying where there are gaps and correcting them. Then the other challenge that we also were a bit disadvantaged when we introduced Taifa Care in Vihiga County. You realize Vihiga County did not have, Taifa Care did not have the LCG. So we had to really persuade our providers to just ensure that they are placing a hard copy of the labor care guide aside, so that when they are admitting the mother with the Taifa Care monitoring labor, they have to come back on the hard copy of the labor care guide so that they can chart on the hard copy adequately, so that we can follow and exactly know how the labor was monitored. So that was quite a challenge, but we hope the ministry will soon be able to ensure that the LCG is actually on the Taifa Care. So we are hoping that is going to be taken positively, and that will go on. So the mentoring process, I told you we do the low dose, high frequency. So some of the mentors, like those that have been on night duty, may not have adequate time for the whole procedure. So the low dose, high frequency, what we normally ensure is that we teach, like we can teach on supportive care and how it started. Then we let them practice how it is charted. Then after they are good on that, then we can go on to the baby, on the parameters that entails the baby. Then we now, when teaching on the parameters, we also have to teach them on how to identify the occipital positions so that they get it and they can accurately chart it. So we go slowly but high frequency. So mainly we are using our 20 mentors plus the coordinators at a facility level that have already grasped the idea of the LCG, and they are able to chart that very well. Then again, we hope that we will continue having our training sessions, and we will be able to scale up to the remaining of our facilities. So we also have opened our WhatsApp groups in our county, and these groups also help us support our mentors and our mentees on how to continuously fill the LCG. Some of them will ask questions on the WhatsApp group, and we are able to address the questions as appropriate. Then each trainer, each mentor again is allocated a group of providers, and whom they will follow slowly. Then they are able to support them, and then to ensure that they are up to par with the filling of the labor care guide. Then it is the master trainers who analyze the reports that are identified and are able now to give back to the facility on their performance. On monthly, each facility will be told maybe that your score was at 70%, but the area that you need to tackle on which you didn't perform very. So each area is actually awarded marks. So supportive care will be given some marks. It is given marks. So on supportive care, all the parameters under support care, that's the companion, the fluid intake, the positions, each of them is awarded marks. Then parameters that entail the baby, again, there are marks to it. That is the carput, the fetal heart rate, the decelerations. So each facility is, we check on each labor care guide and award marks. We fill a checklist, then we summarize, and then the master trainers will analyze the reports and be able to give feedback to each facility so that they know which area they did not perform well, and then come up with a work plan to help them improve on the area that they are not doing very well. I think that is what I can say on the labor care guide. Maybe, yes.
Thank you. Thank you so much, Veronica, for a very, very clear and detailed presentation on the experiences from Vihiga County, how you've managed to organize your services and using the mentorship approach. Next, I want to invite the next presenter from Homabay County, Lorena Akinyi. Will take us through how they've strengthened documentation and the supportive care, because those are some of the questions that were asked from the last webinar. Lorena, the floor is yours.
Okay, welcome to this session. I'm Lorraine Manguru, Nursing Officer, Homabay County Referral. I'm going to take you through documentation and supportive care in labor care guide. Okay, Homabay County has 9 sub-counties. We have 326, 3,226, 624 women of reproductive age, and expected delivery, we have 45,656. And as you can see, you can now see the sub-counties highlighted at the sides. So next slide, kindly. LCG adoption in Homabay County. We have 105 health facilities that have adopted LCG since June 2025. Adoption spans the GOK and both the faith-based and private health facilities. 20 TOT so far, we have 38 in all the leading facility level mentorship and also monthly audits. So we normally have facility monthly audits for the peripheral facilities, but for the referral hospital, we normally do it bi-weekly. So this will help us to identify gaps addressed through structured on-job mentorship. So the audits are always, they normally have a team. We normally sit down, like for the peripheral facilities, the mentors are able to move to the facilities and we audit the files so that we can know where the gaps are and address them real time. And there are normally scores at the end of the session so that we're able to know which areas are not performing well and need to be strengthened. Next slide. So strengthening documentation through LCG approach in Homabay County, improving documentation by strengthening consistency in monitoring maternal and fetal parameters. So the LCG also give us clearer timelines for labor progress. That is the cervical dilatation, the contractions, and also the fetal, it will be the descent. So there's better accountability. Each entry is traceable to the attending provider. If you check at the LCD, there's a column at the bottom part where we normally write initials, but we don't do initials, we do our name. So I'm able to trace the person who did the documentation, and just in case there's a gap, we address it real time. So with good documentation, there's better accountability. There's reduced documentation gaps due to structured sections and structured sessions and prompt. Just a minute. I can't see it well. Okay. And again, in documentation, there's enhanced monitoring and timely decision making. So there's early identification of deviations from normal labor through the reference thresholds. Remember, we have the alert columns, which will tell us if there's any deviation from normal labor. So when now a deviation has been noted, there's prompt escalation for complications such as slow progress, fetal compromise, also maternal exhaustion. And again, through enhanced monitoring, there's also improved communication. There's improved communication among staffs during handing over to enhance continuum of care. So documentation also help us in monthly audits. This normally helps to minimize data gaps and inform peer mentorship. In monthly audits, like I said, we normally every section of the labor care guide is scored. So any section you're not doing well, we are able to organize mentorship so that we can improve and address the gap. Next slide. Okay, so in relation to supportive care under the LCG framework, there's improved respectful maternity care, there's enhanced privacy, dignity, and informed choice, more consistent offering of non-pharmacological comfort measures. Remember the components of the supportive care, we have the companion, we have the companion, we have the maternal position, we have the pain relief. So with LCG, that has helped us to improve them respectful maternity care. So, and again, the more intentional clinical support. There's routine assessments of pain, positioning, and well-being, clear prompts in the LCG guided consistent supportive care, and enhanced continuity during handovers through better documentation. And again, this has also strengthened woman-centered care in that there's increased focus on comfort, mobility, hydration, and emotional support. There's encouraged involvement of birth companions as recommended in the LCG. Remember now the LCG, the birth companion is now coming in, and in case of this and the mother and the companion are all involved in decision making. So there's improved communication between providers and mothers. Women are also allowed to choose their comfortable birthing positions. So a woman is not forced to just adopt one single birthing position, but they're able to choose whatever position they are comfortable. Okay. Next. So back. Improved quality care. Supportive care in LCG. Like I said, it allows birth companions, healthcare workers assess pain, encourage oral fluids and positioning, and co-create a management plan. So hourly alert signs. So here, with the LCG, the healthcare provider is able to assess. You first assess, and then you record. By recording, you now get your reference at the alert signs. Then you are able now to make a plan of action. So there's also improved outcomes. Homabay, so far with the LCG, Homabay has showed a downward trend in maternal and neonatal mortality. Between May 15th to September 6th, financial year of 2025, we recorded 0 maternal death, and this was a plus to us. So there's improved quality care of both intrapartum and postpartum period. Next slide. So basically, learning journey with LCG in Homabay County. There is improved detection of prolonged labor and fetal distress. It has also enhanced closer monitoring of mothers and better monitoring of the fetal heart rate. This has prompted us to have good maternal and neonatal outcome. There's also fast identification of warning signs and decision making. Remember, with the LCG, there's the alert. You are able to assess. After you assess, you record, and with your record, you are able to check the reference thresholds, which will tell you if it is an alert and action should be taken. It has also helped us with supportive care. We are now seeing the companion is now coming into care. The mother and the companion are able to be involved in decision making. Okay, mentorship. Frequent mentorship has reinforced basic midwifery care skills. Currently, we have skills lab, and we're able to learn when we notice a gap. We go through mentorship session, and we're able to get skills so that so we are able to learn basic midwifery care skills. This helps us in managing this mother both during the intrapartum and the postpartum period. Okay, this has also reduced longer rushing to operating theater if second stage takes a bit longer. Remember, the LCG is now giving us timeline. So if all the parameters are okay, so we are able to continue monitoring this mother. With LCG, we've reported fewer stillbirth reductions in perinatal mortality. So challenges so far, we have not all staff have been trained. Still, the mentorship sessions are going on. And at times, like in the referral facility, getting these staffs all at the same time is a bit difficult. So this brings about some staff not yet trained, but we are able to come up with a work plan, and the mentorship sessions are ongoing, and we hope to reach the entire team. So currently, urine dipsticks are not available in most, like in our maternity department. We have it in the lab, but within the facility, in the peripheral facilities, they are not there. So it's still a gap. This lab works like the urinalysis. We have to take the sample to the lab. So currently, the ministry is working on ways on how they could procure more urine sticks, and they make it available at the maternity department, and so that urinalysis can be done real time. So issues of understaffing is also a challenge. So at times it's hard to adequately monitor, because mostly at night. This is a challenge at night, but this is a gap that we soon will overcome. So I think that's basically what we have in Homabay County. And thank you so much.
Thank you so much, Lorena, for a very comprehensive experience from Homabay County. Homabay County is among the few counties that have implemented the labor care guide in their facilities. So for our participants, continue posting your questions. Kindly, if you have any question that you need answered, post them in the Q&A section. You can use the chat box, however, to post your names and the hospitals where you're joining from. But for any questions that need to be answered, kindly use the Q&A. You can also raise your hand if you have a question that needs to be answered. The panelists will be able to respond to most of your questions at the end of the presentation. So keep the questions coming. Keep raising your hands if there's a question that you have and need to be answered. So next in line, we want to hear the initial experience on the use of the labor care guide and how Nairobi County has facilitated the adoption of the labor care guide in private health facilities. To take us through this is Robina Anene, who is the County Reproductive Health Coordinator. Karibu, Robina.
Thank you. Thank you so much, Dr. Otole and team, for giving Nairobi County an opportunity to share this experience. I just want to put on record that we are the youngest on the team, and so we are going to share the little steps that we have made within the last 3 months since the team from MCGL engaged us mid-November. Thank you and welcome to this presentation. And so to begin, I would wish to lay a foundation of Nairobi County so that as we continue, we are able to understand the context from which we are speaking. And so it's good for us to appreciate that Nairobi County serves close to 5 million people, and of them, 169,848 are expectant women, and approximately 168,829 children under the age of 1 year. 60% of this population live in informal settlements. And so just as Dr. Gwako said earlier on, that this labor care guide approach not only is evidence-based, but also informs care to our mothers respectfully and offers them individualized care. And so for the larger percentage of our population who live in the informal settlements, you can be sure they will really benefit from this approach. In those communities, 7,820 CHPs support our communities in Nairobi County. We have a total of 1,372 health facilities. Of them, 953, which is 69%, are private facilities. That is a huge number. 8% are faith-based, and 300 13 of them are public facilities. That's just a small portion of 23%. We have 530 ANC, antenatal care sites, 322, which is 61% of them, are private, 143, which is 27%, are public, and 65 of these facilities, which is 12%, are faith-based. Again, now that our focus is on labor and delivery, we have 235 delivering facilities, labor and birthing facilities. And that gives us an approximate of 73% of them are private. Please take note of the number of the magnitude of private facilities that we have in Nairobi County. 35 of these facilities are public. We recently opened the Riruta, and so that number shifts to 35 public facilities. We also have 53 of all these skilled birth attendants in GOK. Now you can appreciate the shift. We have many private facilities, but our clients trust the public facilities. So 53% of them access care in our public facilities, while 35 access care in private facilities and 13% from faith-based. With this background, I want to share that by the time we were engaging with MCGL, we have undergone several industrial actions, but labor does not pause. So we still have to serve our community. And so when the MCGL team came on board, we embraced them. Please let me have the next slide. We embraced them, and the approach was, they engaged us and got very good buy-in from the leadership of Nairobi County, headed by the chief officer herself and the directors, together with the head of primary health and family health, and all the unit heads, including reproductive health, the child, newborn and child unit, quality improvement. All the unit heads really appreciated this approach when it was introduced to us at the county. And so we had the county orientation, where after the buy-in, we were open to onboard a team of mentors who went through 7 days rigorous training, sitting, facility-based. I remember we engaged in Mama Margaret, our newest level 5 facility, and we were there one-on-one with the trainers from MCGL. And with that, we were able to support. And I want to put on record that Nairobi County has 17 sub-counties, within which we have 7 facilities with theaters. And these are public theaters who are serving our community. So we not only focused on the sub-counties, but we also drew mentors from the big facilities. We call them Big 7, the Big 7 facilities with theaters, so that as we are rolling out, we roll out to and infiltrate all levels of facilities. And so these team members went back to their facilities to now engage with the service providers qua ground. That really helped us in having a pool of coordinators who could support us in across all levels of facilities. And so we were ready to cascade and roll down the labor care guide approach in our facilities. Next slide. And so, yes, this is the current situation. And I'm proud to say that implementing the labor care guide is doable. Because if in Nairobi we have been able to achieve 61 labor care guide mentors trained across all the 17 sub-counties and the big 7 public facilities with theaters. We have also managed to reach 297 maternity staffs across these sub-counties and 197 facilities reached, and they are receiving continuously mentorship on labor care guide. I think it is doable, colleagues. So 59 of them, of these delivering facilities, have been able to fully transition from the traditional pantograph and have adapted the labor care guide. And please take note that these 57 facilities, most of them are private. And if you ask me why, I already said earlier, it is because at the time when NCGL was coming on board, Nairobi County has experienced quite a number of strikes and industrial actions. And so we focused on the private facilities who are still offering services to our clients. Next, and so we have a little picture there where we are engaging, our mentees are engaging in during the mentorship sessions. And so before we roll out to the facilities, one thing that we do is we sit down with the NCGL team and plan together, so that as we kick off the training, we are not running up and down looking for XYZ. So this is one of the pictures where one of the sub-county, and this is Embakasi East, are engaging with the team members so closely to ensure that when they kick off the mentorship in the individual facilities, they are up, their game is up. Next slide. And so, yes, there's no journey that goes smoothly without challenges. We have experienced a few challenges, and just like my Vihiga counterpart said, the detachment and lack of free flow from the EMR system and onboarding of the labor care guide into the EMR platform has been a challenge, and I'm sure MOH are hosting this meeting. They should be able to support the counties to ensure that labor care guide is fully loaded in the Taifa care system. Then variable availability. Some mentors, some facilities could have less mentors, other facilities need more. So those variations and inconsistencies in mentor-mentee availability could somehow have affected the full rollout and the full shift from the traditional pantograph to labor care guide. But you can be sure we are on top of our game, and we will be able to balance this, because recently we were able to train more trainers. And so again, we have mixed uptake volume sites, like maybe the big facilities need a heavier approach, need more mentors, need more time. The changes in shifts again could really hinder that cascading down. Next. And of course, we have a big vision as Nairobi County, and we think that if we engage in these next steps, we will be able to infiltrate and saturate all the healthcare providers in our facilities, and so that we register 100% transition from pantograph to labor care guide. And so these are some of the approaches. Whole site orientation or whole site mentorship, where all the team members, irrespective of the cadre, irrespective of the service point, are mentored are made aware of the shift, though gentle, but everybody needs to start preaching this gospel of the shift from pantograph to labor care guide. Again, I cannot overemphasize the EMR integration of labor care guide, and Dr. Our friends from MOH should be able to speak to this and just support us so that the transition is smooth. Again, strengthening QI structures. One of the things that we have agreed as the leaders in the RH space in Nairobi County is that we pick the shift as QI projects in especially the public facilities, because they seem to have joined a little late due to the strikes. We pick this shift as QI projects so that we gauge, how it is taking up, and we like follow the immediate outputs of implementing and shifting to the labor care guide. Then scale, mentor, pool, and data use. Of course, evidence goes a long way in ensuring that we not only provide quality services to our clients, but we also give these pregnant women quality babies. And in addition, the experience of our moms when they come to our maternities, our focus as Nairobi County is to just make sure that our women are getting quality service, we are giving them quality babies, and that they are enjoying their experience of stay with us within our facilities, both private, faith-based, and public facilities. Next slide. And what are the key takeaways? When we sit back and reflect, the last 3 months, first quarter is done. What are the key takeaways? Nairobi has proudly managed to establish a sustainable mentorship-driven model within 3 months. We have also spread our wings to private, public, and FBOs. And we have even trained drone TOTs from the private and public facilities so that they help us spread this mentorship gospel in labor care guide. And then we also have a path full of adoption. We are in the digital world, so we really require to digitize this and integrate whole site, again use the whole site orientation and mentorship approach so that everybody knows that we are shifting from the patograph to labor care guide. Improving standards. Labor care guide is already improving standardized decision making and accountability in labor management. And what I have gotten from the ground and the teams, they are really appreciating this labor care guide because it is more client-centered. The client is more involved in their own care. And that is what we are all preaching. Our communities to take responsibility of their own health. Next slide. Na kwa hayo machache tunashukuru, asanteni kutusikiza. Back to you, Chair.
Thank you, Robina, for again a very elaborate presentation about labor care guide implementation in Nairobi, all the Nairobi County. Now, in 2019, when the World Health Organization wanted to know whether the labor care guide that we're discussing today is acceptable, feasible, and usable in a clinical setting, they reached out to 6 countries. Kenya was one of them. And in Kenya, they reached to the University of Nairobi to conduct a study on the feasibility, usability, acceptability of this guide. University of Nairobi is a Siamese twin to Kenyatta National Hospital. So in that 2019, obviously, the study was done in Kenyatta National Hospital and St. Mary's, among 12 other hospitals in the whole world. So it's no wonder that Kenyatta National Hospital was the first hospital in Kenya that adopted the use of the labor care guide. So to take us through how they introduced the labor care guide and how they've sustained to use the labor care guide in a national referral high volume hospital is none other than Dr. Philomena Oende. Dr. Oende, karibu.
Thank you very much, Dr. Gwako, for the introduction. And today I will share our experience in introducing and sustaining the World Health Organization Labor Care Guide in a national referral high volume maternity unit. We have seen that the Labor Care Guide is a modern alternative to the traditional pathograph. It promotes evidence-based, woman-centered labor monitoring and timely decision-making. So in my presentation, I will briefly cover why we introduced the Labor Care Guide, how we implemented it at Kenyatta National Hospital. I will also discuss a few strategies that helped sustain its use and some key lessons from a high volume referral setting. Our experience may provide practical insights for other tertiary hospitals implementing the Labor Care Guide. Next slide. So, ladies and gentlemen, intrapartum care is critical for reducing maternal and perinatal mortality by a third and also 50% respectively, as effective labor monitoring allows early detection and management of complications. Therefore, the WHO Labor Care Guide was introduced to replace the traditional pathograph and improve labor monitoring. It emphasizes woman-centered care, as has been mentioned, evidence-based monitoring, shared decision-making, and early identification of complications. However, introducing new clinical tools in high-volume referral hospitals can be challenging, and this is due to large patient loads and complex care environment, which makes implementation and sustainability an important focus, which we are going to look at today. Next slide. Next slide, please. Kenyatta National Hospital is the largest national referral and teaching hospital in Kenya. We manage over 10,000 deliveries annually, and the labor ward has a bed capacity of 37, within which we house an acute room, or what we also refer to as a high dependency unit. We also have 2 maternity theaters that run 24 hours a day without stopping, 365 days a year. So our hospital serves as a major training center for medical students, for fellows, for registrars from the University of Nairobi, for interns, for midwives, clinical officers, therefore making labor ward a very busy learning environment. However, the labor ward faces several challenges, including high patient volumes. And I really applaud Robina for speaking the truth about the county strikes. And we bear the burden when Nairobi and the larger metropolis is on strike. We also manage very complex referral cases. We have multiple cadres of healthcare providers and a significant documentation workload. So these factors make the introduction and consistent use of new clinical tools like the Labor Care Guide particularly challenging in such a high volume setting. Next slide. So the Labor Care Guide was introduced to improve the quality of intrapartum care. And this was in 2018. Then COVID happened. And so we were in the pilot for the labor care guide in collaboration with the University of Nairobi. Later on, we had a phased introduction in 2021. Then come 2022, we phased out the traditional partograph completely. And from that time, we use the WHO Labor Care Guide. So this tool strengthens labor monitoring, respectful maternity care, clinical decision-making, and communication among healthcare teams. And compared to the traditional partograph, the Labor Care Guide also introduces new elements, including monitoring of supportive care. I know this has been asked in the Q&A, shared decision-making with the woman and woman-centered indications. So these additions on the WHO Labor Care Guide help promote safer, more respectful, and more responsive labor care. Next slide. This tool monitors several key aspects of labor care. I think my co-panelists have done justice to these segments of the labor care guide. And these include supportive care for the woman. Remember, this is new. It also monitors the baby, it monitors the mother, it tracks labor progress, documentation of medication or any interventions during labor. And this tool also emphasizes shared decision-making with the woman and concludes with a summary of labor outcomes. So these components are also, we have incorporated this in the labor care guide audit checklist that we use. And this helps assess the quality and completeness of the documentation and clinical monitoring. Next slide. So the implementation of the WHO Labor Care Guide at Kenyatta National Hospital focused on three main strategies. First was leadership engagement, ensuring support from departmental leadership and active involvement of both obstetrics and the nursing team. We work together with the midwives. In fact, I'm very proud of our midwives because in the pilot team, we had 20 midwives. Since then, nearly 100%. Probably the new ones are the ones who require mentorship, but all our midwives are comfortable using this tool. Secondly, there was staff sensitization. So the initial pilot, we had 20 midwives who were trained. Subsequently, we sensitized all the teams until we reached a critical mass where the midwives were able to train other midwives. And also we have registrars, we have consultants, clinical officers, interns, neonatal nurses, nurses in training, as I mentioned before. So through our initial core team of midwives, then they were able to train the others within our department. And then thirdly, there was integration of this WHO Labor Care Guide into our routine workflow, where the Labor Care Guide was incorporated into maternity files. In fact, it is indexed as KNH 329, and all patients coming into labor ward have this tool in the file. We also have aligned with existing labor ward processes to support consistent use. Next slide. We have built capacity over the years. You can imagine since 2022, when we phased out the traditional partograph. And building capacity included clinical training sessions and simulation-based training to strengthen practical skills in labor monitoring. Mentorship was supported using simulation tools, and in addition, continuous clinical mentorship was provided for midwives, registrars, medical officers, interns, obstetricians. And since 2022, we have released more than 100 obstetricians and gynecologists having passed through our hands at Kenyatta National Hospital. Next slide. Continuous monitoring is essential to ensure consistent and correct use of the labor care guide. And at Kenyatta National Hospital, this is supported through the use of a labor care guide audit tool for documentation review. The audit assesses key sections, as I mentioned before, such as the biodata completion. It captures supportive care. I will speak to this later. It also captures documentation, baby monitoring, labor monitoring, medication records, and labor summary. So these structured indicators help identify documentation gaps and guide quality improvement efforts in our labor ward. Next slide. So the department set clear targets to support institutional adoption of the WHO Labor Care Guide, and this included sensitizing over 400 nurses, conducting regular labor care guide implementation audits, and maintaining continuous staff sensitization. And the audit findings are shared with the teams, and recommendations are implemented to improve practice. So together, these activities help strengthen sustained use of the WHO Labor Care Guide within the department. Next slide. We have faced challenges in implementation because we are a high volume referral hospital. And these challenges include high workload in the labor ward. Sometimes we go 4 times our capacity, especially when the county facilities are on strike. And this can limit time for detailed documentation. We have also found it difficult to implement one of the components of having a birth companion, especially when we have an influx of patients and we use all the available spaces to manage women in labor. So this has been a challenge. And there has also, initially we had a bit of resistance, but we were able to overcome that. And when we have many patients, of course, there's documentation fatigue among staff. So operational challenges such as printing did happen while we were when we introduced this tool, but that has been a thing of the past. In fact, when papers run out, it is treated like any other critical medicine because this is a very important tool in ensuring proper management during labor. Integration into existing maternity files initially was a challenge, but we did manage that. And you see, we are talking about 4 years ago. And for now, we are going fully digitized, and we are speaking with our digital developers to incorporate this or integrate the labor care guide into the digital platform so that we are able to use it. Next slide. Several factors supported the successful implementation of the labor care guide at Kenyatta National Hospital. I've mentioned strong leadership support for both the department and nursing leadership. In fact, the labor care guide was included in the nursing and midwifery policy at Kenyatta National Hospital. There was also facility ownership from inception, ensuring the availability of the labor care guide tools and forms. There is also continuous bedside mentorship and handovers with labor care guide, regular training. We have 8 mentors, and these also act as our champions. They also participate in the national platform, training and mentoring other facilities. Within our hospital, they also train the consultants, the registrars, and other cadres. Finally, partnerships with Ministry of Health and implementing partners strengthen implementation and allowed sharing of lessons learned across facilities like we are doing today. Next slide. So early experiences from facilities implementing the labor care guide have shown several positive outcomes, as you have seen, and these include improved labor monitoring, better documentation, and enhanced communication amongst healthcare teams. The labor care guide has also encouraged greater involvement of birth companions and more structured clinical decision making. And overall, these improvements contribute to better quality of intrapartum care and improved maternal and perinatal outcomes. Next slide. Several important lessons emerged from implementing the WHO Labor Care Guide. First, strong leadership commitment is essential to support adoption and sustain practice change. Second, continuous mentorship and bedside support are more effective than one-time training, as you have seen from the other centers. Regular audit and feedback mechanisms help maintain good documentation and reinforce correct use. And finally, integrating the labor care guide into existing documentation systems, ensuring multidisciplinary engagement significantly improves uptake and sustainability. Next slide. Therefore, sustaining the labor care guide requires deliberate strategies. These include regular labor care guide audits and continuous staff orientation to maintain awareness and correct use. Integrating the labor care guide into training curricula ensures the new healthcare providers learn the tool early. Additionally, including labor care guide in national guidelines and embedding its indicators into quality improvement programs helps institutionalize its use and support long-term sustainability. Next slide. The take-home message, colleagues, is that the labor care guide is an important tool for improving the quality of intrapartum care. Even in high-volume hospitals like Kenyatta National Hospital, successful implementation is possible with strong leadership support, structured training, continuous mentorship, and regular audits. And ultimately, sustained use of the labor care guide requires institutional ownership and integration into ongoing quality improvement systems. My last slide, please. I wish to acknowledge the Ministry of Health for leadership in promoting the WHO Labor Care Guide, and special appreciation to my able team of consultants, able team of midwives. I'm proud of our midwives and obstetricians and gynecologists and other cadres who support us in Kenyatta National Hospital. I also acknowledge the county and national labor care guide implementers and partners supporting scale up and shared learning across facilities. Thank you for listening to me. Back to you, Dr. Gwako.
Thank you. Thank you so much, Dr. Wende, for a very detailed and clear presentation. So, ladies and gentlemen, you've heard from the early implementers of the labor care guide. Yes, it's feasible, it's implementable, and it is doable. So now it's our chance to listen to you in form of a Q&A. So for those who have any questions, kindly post them on the Q&A section. You can also raise your hand if you have a question that you need to be answered. I see a few raised hands. So we'll start with Jane Karanja. Your hand is up. You can unmute and ask your question. Jane Karanja, you can unmute and ask. Next, we have Ferishina Kigathi. Your hand is up. If you can unmute and ask your question. Wilson Mugambi. Okay. Probably they have challenges with their technology, so we move to the Q&A. So therefore, the panelists, I have a few questions for you. So the first question is from Daniel Muthiani. This will go to Veronica. Veronica, you talked about accelerations and especially the late decelerations in Vihiga County. So there's a question about accelerations and decelerations. Do you have CTGs and how did you go about it? Veronica, you talked about decelerations. How did you have to use a CTG to pick the decelerations? Or how did you go about it? As you preparing to answer that question, the second question still goes to you. So Kenyatta has already said they evaluated the trends of improvement in obstetric care and outcomes. So at Vihiga, there's a question from Odongo. Have you tried to evaluate the trend of improvement in obstetric care following the rollout of the labor care guide? Veronica, kindly, if you can unmute and respond.
Yes, in Vihiga County CTGs, we have 3 CTGs in our 3 county referral, one from the county referral hospital. We also have another one at Mohaya sub-county and another one in Hamisi. So those are what, and we're oriented on how to use the CTGs and be able to detect the decelerations. That is the late decelerations. Also, monitoring the doctor, the checking the provider, take the hand, then
Sorry, apologies, Veronica. We can't hear you. I think something to do with your audio. Veronica, we can't. Veronica, we can't hear you.
Okay, house here we have CT machines, and our providers were oriented on how to be able to detect the fetal decelerations using the CTGs, the late decelerations. So again, when monitoring without the CTGs, we also have to teach our provider to be keen when checking the fetal heart rate during contractions, so that they are able to detect after the contraction ceases. Is the fetal heart rate able to pick up and go high, or does the low fetal heart continue for a few more minutes? That is after the contraction has ceased. So that helps in the midwife identifying that there could be a late deceleration. So in normal circumstances, when the fetal heart rate, when the contraction stops, we expect that the fetal heart rate should come up. But when it stayed down, then we are able to know now there could be a late deceleration in such a case.
Thank you. Thank you, Veronica. We missed quite a bit, I think, because of the audio. But if I heard you well, so when you're using the labor care guide, yes, you'll be able to pick fetal heart decelerations without necessarily using a CTG machine. Remember the good old way of monitoring a fetal heart rate. You start monitoring before a contraction, during a contraction, and after. Pretty much what Veronica said is that the fetal heart rate is supposed to remain the same before, during, and after contraction. So if there's a dip during the contraction and it returns to baseline immediately, you'll say that is an early deceleration. if the fetal heart rate dips after the end of the contraction and stays low for some time, then you'll say that is a late deceleration, which now in the labor care guide will be marked as an alert requiring some action. Thanks, Veronica. So the next question is from Dr. Tony Opar. This goes to all the panelists. Thank you for a good session. For the facilities that have adopted the labor care guide so far, can you say the LCG has improved your fetal maternal outcomes compared to the pathograph? So Lorena, you'll go first, Robina, and then Dr. Wende. What has been your experience with regard to the fetal maternal outcomes? Lorena, in Homabay.
Hello. Personally, I could defend that LCG has given us a good outcome in terms of maternal and fetal outcome. Remember now with the LCG, you are able to identify the danger signs and act on it real time as compared to the traditional pathograph we had. So just because the interventions are real time, we're able to get good outcomes because we're able to assess and you're able to compare you're able to compare the alert column with whatever your assessment is, and if at all it is an alert, you are able to act immediately. So LCG being evidence-based has given us a good maternal and neonatal outcome.
Thank you, Lorena. I know you also mentioned a decline in the stillbirth rate. Do you have the numbers?
Pardon?
In your presentation, you mentioned that the stillbirths have gone down since you started using the labor care guide. Could you have the numbers?
I can get the numbers.
Thank you. Robina, what has been the experience in Nairobi County?
So far, so good, Daktari. Thank you for the question and the concern from our colleague. I can single out a few sub-counties who took up the shift quickly and in good time from the time of mentorship, that a sub-county like Makadara have actually registered 0 maternal mortalities from the time of implementation. And so, yes, the outcomes are gradually improving. Thank you, and back to you, Dr. Ray.
Thank you, Robina. Dr. Wende, this question was asked in the last webinar. It has been asked again. What is the experience from Kenyatta? Has it improved the fetal maternal outcomes?
Oh, thank you, Dr. Gwako. For KNH, let me start by saying that it's a very complex system in the sense that we see very complex referral cases. We have done audits based on the sections that I mentioned, but aggregating the data to see we followed.
Dr. Wende, I also keep
Kenyatta
losing you.
National
I don't know if it's my
Hospital,
network.
and those who are, I don't have the data yet, but am I audible? Am I audible now?
Yes, you're audible now.
Yes, so what I was saying is that we are in the process of disaggregating the data to see how the outcomes look like for the referral cases and also the patients who start care within our facility. So very soon we'll be able to generate that data. However, the labor care guide audits are still continuing. And then Robina has just mentioned about Makadara having no maternal mortality. I just like us to be very careful about such pronunciation about zero maternal mortality, because some of the mortality is actually referred to KNH. So we bear the brunt that yes, our facility X might report zero maternal mortality, but that mortality was referred to KNH. So it's something that we have to be very careful about. Back to you, Dr. Gwako.
Thank you, Dr. Wende. I agree with you when you are also looking at the effectiveness of the labor care guide. Remember, the focus mainly, most of the time, will be on the fetal and neonatal outcomes, not necessarily maternal, and also a reduction in the unnecessary cesarean sections. So there are a couple of questions on the new section on respectful maternity care. There are quite a couple. I think this is the last question we're going to ask. So RMC is one of the components that have been introduced in the labor care guide. And there are several questions. For example, how have you guys implemented the issue of having a companion, mobility, and pain management? Taking into consideration the issues of space, cultural norms, and resources with no budgetary allocation. So how did you handle the issue of respectful maternity care? That's from Judith Elavian, plus I think 5 other questions asking about the RMC. Again, we start from Team Vihiga, Homabay, Nairobi. We close with Kenyatta. For the audience, please don't go. The next section on, we are still listening from, also hearing you out. So in the next part, as we finish, I'll invite Dr. Otori to take us through a poll. We want to hear your opinions about how the webinar went, how and what other topics you want us to cover next time after the panelists have answered the question on respect to maternity care. So Veronica, how did you handle the issue of RMC? Companions, mobilization, feeding, pain management.
Okay. So the issues of companion, so our providers normally are encouraged to call in case the patient, the client does not come in with a birth companion. So we have to call somebody, and it also depends if the client is also agreeing to the fact that she wants a companion or not. So we normally ask the client, would you want somebody to be with you during the labor process? So if she says she doesn't have and she says she wants, so we normally request that they can call someone to come, or we call on their behalf. Then they are able to join the management. I didn't get the next question very well. What was the next question?
For respect to maternity care, it was about
Yes.
pain management.
Oh, pain management.
Pain
We
management,
also, okay, so we normally focus more on the pharmacological pain management. We have the round balls, the big balls that we'll have our mother sit on. Then we also have some music in our labor ward. The mothers can concentrate on the maybe listening to the music as they labor. Then we also have students that we will encourage to keep at least that helps in soothing the back. So many times we use the non-pharmacological pain relief methods.
Thank you, Veronica. Homabay, how have you managed the issues of birth companion, pain management, feeding, and position, ambulation?
So basically, it's the patient has to consent. If at all the patient has to consent, if at all she opts to have a companion. And also another thing, if the patient does not consent to have a companion, the patient is not forced to, but it is basically an individual decision. Then another, again, you talked about what else apart from the birth companion? I can get the question.
Companion, pain, feeding, and ambulation.
Or with pain, basically we measure most on the non-pharmacological. What we have currently in our labor room is the music therapy. So we play for them some music. And for ambulation, we in terms of spacing, there's no issue. They're able to ambulate around with their companion. So the companion becomes a challenge when we have 2 delivery coaches in a room. So when another delivery is taking place, it's hard to have this companion because of the privacy issues. But not all the time we have a high number. We have 2 mothers delivering at the same time. When you have space, the companion is always allowed to be with the mother also during childbirth. But most of the time through ambulation, the feeds, the companion plays the part. You only monitor because there's still issues of understaffing. But basically with pain relief, we just measure on the non-pharmacological. Thank you.
Thank you, Lorena. Robina, how are you handling the RMC issues in Nairobi County?
Yeah, just like my counterparts have said earlier, we are still just using the recommendations within the labor care guide, like encouraging ambulation, small little feeds with as the labor progresses, so that mom does not go into hypo. So we are just sharing the same approaches as my counterparts have shared earlier. Thank you, and back to you.
Thank you. And lastly, Dr. Wende.
Yes, thank you, Dr. Guaco. For us, it started with a culture change for our patients and our doctors and midwives, and it was integrated into the care at the time. However, as I mentioned earlier, that in such situations, such as during industrial action in the Nairobi County and the larger Nairobi metropolis, we have experienced significant increases in patient volumes. And in these moments, maintaining privacy for all women is, it's difficult because of overcrowding. Spaces become a real challenge. And so as a result, we temporarily limit birth companionship like we did for almost a year, because for almost a year, you remember Robina mentioned that Nairobi County has been on strike for most of the year, and this is to protect the dignity and confidentiality of the women who we take care of. Now, about pain management, I'm privileged to work at the National Referral Hospital, and my department was part of a team that developed a pain management protocol, including obstetric pain management. We have a number of medicines within our armamentarium for pain management, and also we have adopted non-pharmacological pain management options like walking around, asking the women to stand under the shower, though the showers are limited, especially when we have a surge of patients. And in the pharmacological options, we have morphine within labor ward, we have morphine and tramadol We don't have pethidine within our hospital. We stopped it for a number of reasons. And then occasionally for patients who the consultants or the residents or the midwives feel will benefit from epidural analgesia, we do send a consultation to our anesthesia colleagues to they give epidural analgesia for very few patients, and that is when the nursing ratios are very good. So you see probably once in a while we will have a few on epidural analgesia, and then occasionally we have some anesthesia residents doing their study within the labor ward. Like there was one that was concluded on a single shot spinal in advanced labor that really helped relieve pain in women at the time the study was conducted. Yeah, but we do have a protocol, and therefore we can implement. We may not have everything in the protocol, like we included fentanyl for use that might be out of reach because of cost, and also Entonox. Entonox is nitrous oxide. Again, that its use has been limited again because of cost, but it's in our protocol. Thank you. Over to you, Dr. Gwako.
Thank you. Thank you so much, Dr. Wenda and all the panelists. It's 8:30. We promised we're ending at 8:30, but allow us 10 minutes to wind up. Charles, Dr. Hotori, and Nelson for the Pulse poll.
So to our participants on the call, kindly have a look at your screen again. There is a poll posted. Attempt the questions there, and we'll be able to get the feedback from your end. Once you finish, click on submit, and you will be done.
Thank you, Nelson. So kindly, guys, fill this poll for us. It's what will guide us on how well this webinar was covered, and if there are any areas that you want us covered in the subsequent webinars. Can give you 5 minutes as I invite Dr. Nyanjao, the girl with power. Watu wa serikali ministry, guys. Dr. Nyanjao, you can come over for final remarks and the way forward.
Thank you so much, Dr. Gwako and our eminent team of facilitators. I hope our colleagues in the webinar are able to respond to the poll. I saw someone saying they can't see the poll. I hope we are all able to answer those few questions in the poll. And I want to also thank you very much for keeping energies up, asking the questions, engaging us, and showing that interest to learn, to be trained. And I can assure you, it is our day and night job to make sure that all of us have adequate knowledge to serve our clients better. So a few questions were raised, and I think one that has been repeated severally pertaining to availability of the pantograph in Taifa Care. To those who answered, I responded on text. But I want to inform everyone that we are working with the Digital Health Agency to configure the labor care guide inside a structured client form so that it is available the way you would expect to clerk a patient, and also have the labor care guide in there. So that is work in progress. I'm very grateful for your patience, and we are working to accelerate so that for those colleagues who are using an EMR, then you're able to provide the service without having to juggle between paper and your devices. In terms of training, The training on labor care guide is embedded in EMONC. So any training encounters that you will undergo from now on that as is on EMONC, labor care guide will be trained in there. And then there's also the training on the continuum of care package. This is a training for the normative care we provide outside of an emergency. And even in there is training on the labor care guide. So any colleagues who will be having these training sessions coming up within your counties, expect to be trained on the labor care guide, and you automatically become a mentor so that you are able to cascade that knowledge to your other colleagues within the working spaces that you are in. So let's look out for those. If you have partners in your counties, if you're a private facility or a faith-based facility and you're able to collaborate with the county to support a training, please do. If you have any any sponsors or donors, encourage them to support a training so that we accelerate, we make this rollout as fast as possible. There was a question on whether the training institutions will also be onboarded. Yes, we are doing this as a country, both the learning institutions and the service areas. So we are trying to go to do an all 360. It's going to be a bit look a bit fragmented to begin with, but we are trying to put in all the efforts together. So let's work together. Where you have been trained, please be our champion, please be the mentor, purpose to teach others how to use the tool. And where you have powers with you to influence the authority, whether it is the CEO of your hospital or the county government or whoever is a leader within your facility, to provide the document, if you're using paper-based systems, to provide the document so that you put it in the client files. You'll only understand and get used to it by doing. So let's feel encouraged. Go forth. If you have any access to a person who has been trained, let's keep engaging them to pass on the information to others. We are available at the Ministry of Health. We have visibility of partners who are in various parts of the country. So if there is no training that has happened in your county on EMONC or on EMONC, please, through the RH coordinator, please reach out to the ministry and we try and find a way to get that training going. Asanteni sana. I hope you are done with the poll, and I look forward to seeing the other topics that you'd be interested in so that we pass more information on maternal health. Over to you, Dr. Gwako.
Oh, thank you, Dr. Nyanjao. You know, when the government has spoken, we can't speak again, but thanks a lot. And I want to take this opportunity to sincerely thank all of you for creating time to come for this webinar at the beginning of a very, very long weekend. We don't take it for granted. Ministry of Health for facilitating this. Our panelists for very good presentations, and MCGL for organizing this webinar, this particular webinar and the series of webinars that we've been having. So we look forward to seeing you again soon. There'll be communication on when the next webinar will be done and the topics that to be covered. Do have a great evening and enjoy your long weekend. Until next time, good night.
Thank you and good night.